Good morning and welcome. My name is Susan Carroll and I'm the Chief Operating Officer here at Inova Loudoun Hospital, and I wanted to welcome you all to our 2010 breast cancer program. Our theme today is Live, Learn, and Thrive. I'm going to introduce our panel of speakers, and each of the speakers is going to bring a little something different to the presentation about their background and what they do and how they treat the care of a breast cancer patient. We're going to start at the end. Here is Eric Cohen. Eric is a registered nurse with our Life with Cancer program here at Inova. He is the program manager for patient and family education. Next, we have Maia Caramel. Maia is the president and founder of the Tiger Lily Foundation. The Tiger Lily Foundation is a foundation that supports a support network for young women with breast cancer. Then next, we have Grace Ann Fazet. Grace is a master's prepared certified genetic counselor with the Inova Genetics Counseling Program, and she is our program manager with Inova Cancer Services. Next, we have Dr. Chen. Dr. Chen is a fellowship-trained breast radiologist here at Inova Loudoun Hospital Center, and she also works with Fairfax Radiology Consultants. And then next, we have our medical director, Dr. Shannon Lair, who is a fellowship-trained breast surgeon, our medical director for our Inova Breast Cancer Institute program here at Inova Loudoun Hospital. Thank you. So we're going to start today with Dr. Lair's presentation. Okay.
Hi, good morning. Thanks so much for coming out and joining us this morning on such a glorious morning after such a dreadful weather that we've been having for the past 2 days. But we're glad that you're here, and hopefully we'll provide you with some education and information to really kind of arm yourself. So the topic of my talk is take control of your breast health. So I'm going to kind of arm you with things that you can do, sort of lifestyle modifications, preventative screenings, things that you can do to try and decrease your risk of developing breast cancer, and certainly if you would happen to develop breast cancer, detect it at an earlier stage where it's most curable. So I wanted to start off with kind of an audience participation question. So what is a 40-year-old white female who is really of average risk, so doesn't have any specific high risk factors, her personal risk of developing breast cancer in the next 10 years? So I've got a few choices there. So who's going to say less than 5%? You could say with a show of hands. All right, just one, Poonam. All right, 10% risk. All right, a few more. All right, C, 25%. All right. And D, 50%? All right. And then greater than 50%? Anyone going for, okay, all right. Well, I think pretty much all of you, except for maybe Poonam, might be surprised to find out that actually it's only 2.2%. And again, that's for a 40-year-old average risk in the next 10 years of her life. So basically, if you look at it kind of the flip side, a woman has a 97.8% chance of not getting breast cancer starting at the age of 40 for those 10 years. So next audience participation question. So what percentage of Loudoun County women are compliant with the American Cancer Society's breast cancer screening recommendations regarding obtaining annual screening mammography starting at the age of 40? And I have a few answers for there. 22%? Okay, so pretty low, okay. And actually, I'm talking with Susan Carroll this morning. I actually have the wrong percentage, so I'm going to make B 28%. So I'm giving away the answer. So everybody raise their hand. So 54%, 71%, 91%. So the answer is, again, I said only 36, but it's actually even worse than that. So it's actually even awful. So it's only 28% of women in Loudoun County, and that actually is the national average as well. So we are average when compared to the rest of the United States. But I think Loudoun County should definitely be better than average. So we need to work on that statistics for sure. So why kind of is the disconnect? Because it seems like pretty much everyone kind of overestimated the risk of developing breast cancer, but yet the majority of women are kind of not abiding by the recommendations that are currently set out by the American Cancer Society that really have clearly been shown to decrease breast cancer mortality rates. So why is that? So I think really in talking to women and about this issue, I think there are kind of two common misperceptions that are out there that I think really influence women. One is a lot of women overestimate the impact of family history when they're thinking about their own personal breast cancer risk. And certainly we're going to hear from Grace, but Grace, and her kind of genetic issues, with the BRCA gene 1 and 2, that only accounts for about 5 to 10% of breast cancer. So that's a pretty low number. And then only about 20 to 30% is familial, meaning that they don't have a discrete genetic abnormality that we can identify, but do have a family history of it. So the great majority of women who are diagnosed with breast cancer actually have no family history of breast cancer. So, again, a lot of women think they're out of the woods. My mom was fine, grandmother's fine, aunt, everybody's fine, but that's not true at all. And I think also a great deal of women approach mammography being very fearful of it and anxious about it. And really, I'm trying to turn that around and say that really the diagnosis of breast cancer in no way in 2010 is a death sentence. And really, if you're detected at stage 1, which again, that's the whole goal with screening mammography, is that you are detecting at an early stage before it has chance to grow to a large size, spread to lymph nodes, spread to anywhere else in the body. 98% of those patients diagnosed at stage 1 are alive at 5 years, so it has an incredible survival rate. And I'll go to show you, again, just kind of just data to support that really back in, the mid-70s, we were looking at only about a 75% survival rate. And then certainly as screening mammography came on the market, and as certainly our breast cancer treatments are more targeted and we know a lot more about it and really have made leaps and bounds in the past decade as far as our treatment of breast cancer, that survival rates have just asymptotically increased. And really, deaths from breast cancer for the past decade have decreased by 2% every year. So that's just incredible, and that's actually the best breast cancer mortality improvement that we've seen, or organ specific. So we're doing the best that we can with breast right now, but certainly have a lot of room to improve. So really, what can we do as women, and there are a few one man in the audience, what can we do to really, again, take control of our breast health? So unfortunately, there's a lot of non-modifiable risk factors for the development of breast cancer, and I have them kind of all up there listed, and I'm not going to really focus on that, but certainly, can take a look at that and peruse it and say, okay, well, do I have any of those? Because certainly if you do, then you may need to talk to your doctor about what, if anything, additional I may need to do as far as your screening, breast cancer screening. But really, there are, fortunately, modifiable risk factors, things that are in our hands, and a lot have to do with lifestyle. So. Hormone replacement therapy, certainly that was the rage back in the early 90s and through the early 2000s, that really thought that this was kind of the fountain of youth. It's going to be good for your heart, good for your bones. And after the large study came out and had some long-term follow-up for the women who were involved with the Women's Health Initiative, found that hormone replacement therapy actually, with the rates of prescriptions going up, the rates of breast cancer also went up. And so while it hasn't been 100% causally linked, really that is very strong correlative data. And actually, as the rates of prescription for hormone replacement therapy then took a nosedive, same thing with the incidence of breast cancer. So we're pretty comfortable in saying right now that hormone replacement therapy is definitely associated with breast cancer. So especially combination therapy where you're using both an estrogen and a progesterone. Certainly, this is an issue I talk about all the time with women who come into my office. They're like, look, I can't do without my estrogen. I can't sleep. I can't function. I'm drenched in sweat all the time. And we talk about other things that we can use besides hormones, lifestyle modification, antidepressants, things that can actually do not impact your breast cancer risk. So if you do need to use hormone replacement therapy, if that's really the only thing that works for you, I do recommend certainly the lowest dose possible and the shortest amount of time possible. Alcohol use also increases your risk for development of breast cancer, so greater than 1 drink per day. So the data up to, if you just drink a glass of wine at dinner, that does not increase your risk, but something more than 1 drink per day will increase your risk of development of breast cancer. Postmenopausal obesity. So that's defined as a body mass index of greater than 27. But if you kind of think about it from a physiologic standpoint, the fat cells of your body actually create actually convert hormones, other hormones in your body to estrogen. So you're actually kind of, in effect, giving yourself a hormone replacement therapy when you are obese. So, and we already have said that that definitely is linked with breast cancer. So, especially in the postmenopausal state where really your estrogen levels should be low and you are at such high risk of, or you're at higher risk than a younger woman for development of breast cancer. So, certainly maintaining an ideal body weight is very important. Also, postmenopausal obesity has been linked to increased risk of recurrence from breast cancer. So someone who's already been diagnosed with breast cancer and went through treatment, really I encourage ladies to, again, maintain a healthy body weight. We get them hooked up with nutritionists. And the other thing that can help is also exercise. And that can help maintain your body weight. And also exercise of 3 hours per week or greater has been shown to decrease the risk of breast cancer. And then the last thing is breastfeeding. So I don't know if anyone, I'm currently breastfeeding actually. It's a good thing. Breastfeeding is good for babies, but it's also good for lowering your risk of breast cancer. Not quite sure exactly what physiology and why that is exactly, but breastfeeding for 6 months or greater. So again, another reason to breastfeed your children. So what else can we do? And again, it's kind of that, then it's the modification of of your risk factors as well as then, early detection. So right now, the American Cancer Society recommends for women of average risk, again, ages 20 to 39, to really have a clinical breast exam done by a healthcare provider every 3 years, although I certainly support in my office seeing a healthcare provider every year for a clinical breast exam, but the American Cancer Society recommends at least every 3 years. Self-breast exam is, and this was a reversal, not a reversal, but a change in the recommendations from the American Cancer Society, is that self-breast exam is an option. So right now, it's nothing that is highly recommended, but honestly, again, it's another thing that I talk about, that really women should know how their breasts normally feel, normally look, and change, kind of within their menstrual cycle, so that if they notice changes in their breast, that they can, kind of bring those to, a doctor's attention right away. Because as you can see on this, younger women, mammography is not recommended. And the reason why that is, and Jing may talk a little bit more, Dr. Chen may talk a little bit more about this too, is that the tissue is very dense in younger women, and mammography hasn't been shown to really, in this young patient population, affect mortality rate, because it's definitely limited in this patient population. So that's why, especially for the younger folks, I definitely kind of plug along with kind of a breast awareness and just being aware of how your breasts normally feel, because the great majority of women diagnosed before the age of 40 actually found their own cancers. So then for women who are 40 years or older, then we get into the screening mammography. And certainly there was this controversy, I guess that was last year around this time, for November 2009, when the U.S. Preventive Services Task Force, a recommendation came out saying that really, we can't recommend women to undergo a mammogram between the ages of 40 and 49, that really we can't say that this is something that we would recommend as a general population. many people say, well, that was rescinded like about a month later after those recommendations came out. But it really was, they kind of backed off on it, saying that you need to discuss it with your healthcare provider. Is kind of they didn't reverse it, but just said you need to talk about your healthcare provider with the risks and the benefits. And the reason why they came out with these recommendations in the first place was because of the risk of anxiety and false positives, meaning that something shows up on the mammogram and really in the end it turns out to be nothing after a biopsy or after additional 6-month follow-up. But in my mind and in many societies across the country who kind of totally was like, I can't believe you're saying this. We already have enough trouble getting women in to get their mammogram. It was a matter of that to me that's not a good reason to recommend not doing it, is that it's anxiety provoking. Lots of things are anxiety provoking, and there really has been no new data that came out to really support this recommendation. So again, that's why they kind of rescinded things. So. Also, a part of that is have a clinical breast exam done by a healthcare provider every year. Self-breast exam is an option for women of this age as well. And again, women should report any changes that they notice in their breasts promptly to their healthcare providers. In the lobby, I do have a brochure with my business card, and it has a very, very detailed instructions on how to do self-breast exams. So I would encourage everyone to kind of pick one of those up or pick a few up. I certainly have plenty. So, if something's found, okay, don't panic, don't freak out, don't go into denial though, and really most breast signs and symptoms are not cancer, and most abnormalities that are found on mammography are not cancer. 80% of breast biopsies are actually benign, so I have a feeling that a lot of women in here, unfortunately, were on the other end of things, but the great majority of biopsies are negative. So even if you're going in there to prepare for a biopsy, know that the overwhelming majority of the time this is going to come back okay. Again, don't ignore the changes. Also, the important thing too, if you, especially again for younger women, where the breast tissue may be more dense and mammography is more limited, if you find a lump in your breast, even if you had a very recent negative mammogram, you need to go see your doctor about that, because again, mammograms can miss about 10 to 15% of cancer, so they're not the be-all and end-all, although they're still a great test. And so really kind of in summary, for what can I do as a woman to help myself is really know your family history and any of the other risk factors that I showed you. Again, I didn't really talk about high-risk patients because certainly there are other things that we could do, breast MRI, possible risk reduction with tamoxifen, possibly even go so far as bilateral prophylactic or risk-reducing mastectomy. But it's something that you really need to talk about with a breast specialist. So certainly if you feel that you're at higher risk than average, certainly can ask your doctor to send you on to someone like myself. That's certainly part of my practice, is to do kind of a risk assessment and try and figure out what is the best screening protocol for you and what other things we could do to kind of modify your risk. Again, maintain appropriate body weight, exercise, limit your alcohol intake, avoid the prolonged use of hormone replacement therapy, strongly consider breast self-exam, again, especially for the younger women. Get your regular clinical breast exam and get those annual mammograms if you're 40 or over. And hopefully we can report next year an increase in the statistic, and we're certainly something that we're following, and hopefully we'll definitely improve. So, okay, thank you very much.
I'm Dr. Chen, one of the breast imagers here at Inova Loudoun Hospital. So my talk today, I'll speak a little bit about breast MRI. Breast MRI is a new modality for evaluation of breast cancer. Some of you may have heard about it. Some of you may have even discussed it with your doctor. It is considered as a supplement to the more traditional mammography and breast ultrasound exam. It is in no way meant to replace these more traditional modalities. Mammogram remains very much the bread and butter of breast imaging at this time. Breast MRI exams do not involve any radiation. Usually, for the purpose of cancer detection, we use intravenous contrast, gadolinium, for these exams. It should be done with a dedicated breast coil, and usually both breasts are imaged at the same time. It requires no compression, unlike mammogram. So some of the indications for breast MRI will include screening for very high-risk patients. These include patients with a very strong family history, patients with known genetic mutations such as BRCA1, BRCA2 mutations, and also patients who had a history of prior radiation to the chest area, usually patients with cancer such as lymphoma. For patients with a known diagnosis of breast cancer, MRI can be helpful to evaluate the extent of disease if the mammogram is limited. It could also screen the contralateral asymptomatic breast for any occult malignancy before the patient undergo definitive surgery, chemotherapy, and radiation. And sometimes for patients who present with abnormal lymph node that's biopsy and proven to be cancer, it could be used as a search for where the original primary cancer is. And for young patients or patients with a very large cancer diagnosed, sometimes they will be given chemotherapy before the definitive surgery in what we call neoadjuvant therapy. And MRI can be very helpful in documenting is the tumor responding to the therapy. Sometimes patients come for mammogram or ultrasound, and at the end of all these exams, there may be something concerning, but it's not well characterized by these exams, well enough to do a biopsy on. So at this time, you're sort of left at the end of a diagnostic mammogram with your doctor telling you, there's something we see, but there's no way we could really biopsy it, and we'd like to get additional tests to evaluate it further. And breast MRI can be very helpful in those cases. I'll show an example of that later on. And as Dr. Lear has sort of referenced to earlier in her talk, if you have a palpable lump, you come in for mammogram, you come in for ultrasound, and nothing is seen. But based on how the lump feels on physical exam, you or your doctor may be very concerned about it. At that time, an MRI may be helpful for evaluation as well. And because MRI can image from the nipple all the way to the chest wall without compression, it can be helpful in evaluation of patients' breast implants, which mammogram can be quite limited on sometimes. A couple of contraindications to getting a breast MRI. Pacemaker is considered basically a definitive contraindication because MRI is done in a very strong magnet, and the magnetic field can actually cause malfunctioning of the pacemaker. In addition, because breast MRI requires intravenous contrast, such as gadolinium, pregnancy is also an absolute contraindication because a gadolinium contrast is known to cause birth defects in pregnant patients. And then the more recent topic is that patients with renal insufficiency, that's also become a pretty strong contraindication for getting the gadolinium contrast. What I've included are two examples that I want to use to sort of illustrate how we use breast MRI on a day-to-day clinical setting. All right. So the first patient was in her 40s. She's not high risk, no family history, no genetic mutation, and she's asymptomatic. She came in for her annual screening mammogram. On her mammogram, there's a very small lesion that was picked up on the medial portion. Let me see if I can use my pointer. So it was picked up in the medial portion of the breast. Now remember, when you come in for your mammogram, usually two views are done for each breast. One is a craniocaudal image, which is what I have shown here, and another is what's called the oblique image. This little finding was only seen on one view. It was not seen on the other oblique image. So based on these two images, the radiologists know, well, there's something in the medial inner portion of the breast, but is it upper or lower? They can't tell. The radiologist actually went ahead and did an ultrasound the entire medial half of the breast. The ultrasound did not reveal any suspicious finding. So at this time, at the end of her diagnostic workup, the patient is told, there's something we see on the mammogram that we're a little bit concerned about, but we are not seeing it well enough to be able to biopsy it. So the recommendation for the patient was to obtain a breast MRI for further evaluation. On her follow-up MRI, and this is of the left breast, the images are flipped on the MRI with respect to the mammogram. So here's an MRI image from her breast. What we're seeing here is that there's a small irregular mass that's in color, so it's easily seen. MRI basically evaluates how much blood flow is there to a particular area of the breast. The hypothesis is that because tumors grow fast, they tend to have more blood flow within them. So we expect on MRI to pick up cancers that have increased blood flow. What the color is showing is basically documenting how much blood flow there are in different parts. And this irregular mass certainly has more blood flow than the rest of her breast. This was the left breast, which is where the mammographic finding is. But remember, we imaged both breasts at the time of the MRI. So for this patient, the contralateral breast had an incidental finding. It had also an irregular mass that looks very similar to her left breast mass. Both of these lesions, we actually took the patient back to ultrasound to see if we could find it, and we could not see it on the ultrasound. So they actually underwent MRI-guided biopsy, and both were biopsy proven to be small invasive cancers. All right, so that's sort of one use that we use, is that we're seeing something in mammogram ultrasound, but we're not quite there where we could do a biopsy. MRI can be very helpful in those situations. The second patient, so she had a history of prior lumpectomy for cancer. She was asymptomatic. Her doctor sent her in for her annual mammogram. And what I'm showing here are the two views, the oblique and the craniocaudal image of her right breast. The BB marks where her prior surgical scar is. Her mammogram was negative. Nothing was seen. There was a little bit post-surgical changes where her prior surgery is, and that's expected, but there's no suspicious finding. After these mammograms were performed, the patient and the doctor basically decided that because she was at increased risk, they wanted to obtain an MRI for further evaluation. And this image here, this is basically an image, what we call the maximum intensive projection. It's an image of the whole breast that's sort of reconstructed by the computer. What it's showing here is in the superior portion of the breast, there's a small irregular mass, and the red color basically indicates lots and lots of vascular flow within this mass. This was also biopsy proven to be small invasive cancer in this patient. So that was sort of helpful for this patient. It's interesting because her breast tissue is actually not very dense on the mammogram, but there was still, an occult cancer that the mammogram was missing and the MRI was able to pick up. So these are some of, I just wanted to use these cases to sort of illustrate how, we sometimes use breast MRI in the clinical setting. In terms of whether, a breast MRI is indicated for each individual situation, it is a very individualized decision. And, if you ever find yourself in that situation where you're considering getting a breast MRI, it's very important to have a detailed discussion with your doctor.
Hi, so I'm just going to talk in a little bit more detail. I don't have any pretty slides. It's just going to be me talking for a little bit about what Dr. Lair and Dr. Chen touched on briefly as far as hereditary breast cancer and genetic testing for BRCA1 and BRCA2. So I am a genetic counselor. What I spend most of my time doing is talking to individuals and families about whether or not there is a genetic factor that's playing a role in cancer in their family. And most of what I do also is genetic testing for BRCA1 and BRCA2. However, when I sit down with women and I discuss with them their concerns about their family history, oftentimes genetic testing isn't the end result. So I just want to talk a little bit about what types of family histories raise red flags and make me then suggest genetic testing. Because Dr. Lair mentioned that only about 5 to 10% of breast cancer is actually due to genetic factors. Most of the time, breast cancer occurs and we don't know the exact reason. We know some of the risk factors, some of them are modifiable, some aren't. But we do know the two main risk factors that were, again, listed 1 and 2 on Dr. Lair's risk factor slide is age and being a woman. And we know those two factors there's absolutely nothing we can do about, but we can be armed with knowledge about our risk factors such as family history to have a better understanding of what we can do to reduce our chances of getting breast cancer. And so as far as age, the average age of onset of breast cancer is around 60 years old. And so when I talk to women about their concerns about their family history, one of the key questions that I ask is age of diagnosis of cancer in their family. Because if age doesn't seem to be playing a role and people are being diagnosed younger than what we typically see with the diagnosis of breast cancer. So early onset breast cancer being diagnosed in a woman's 30s and 40s. So anything under the age of 50, we consider that early onset. That does raise a red flag because age doesn't seem to be playing a role. So perhaps there is something else like a genetic factor playing a role in cancer in the family. Another important feature of hereditary cancer is multiple generations with cancer on the same side of the family. So if someone has a genetic factor that's putting them at risk for cancer, because we pass on these genetic factors to our children, we can see multiple generations with cancer. Another feature of hereditary cancer is having more than one cancer. One person, because they're susceptible to cancer, getting cancer 2 times or 3 times even in some cases. So for instance, a woman who has breast cancer in both breasts, bilateral breast cancer is considered 2 separate breast cancers. And so that does, again, raise a red flag that perhaps there's a genetic factor playing a role. Men can develop breast cancer. It's very uncommon for men to develop breast cancer. So when we see these rare types of occurrences in families, again, that can make us wonder if there's something hereditary going on. And ovarian cancer, there does seem to be a link, especially with BRCA1 and 2 mutations, of seeing both breast and ovarian cancer together in families. So those are the indications for hereditary cancer. And a lot of the women I talk to, they don't have very strong family histories, but talking and getting a more clear, sharper view of what their risk is very helpful for women, because Dr. Lair also very clearly illustrated that a lot of women can feel that their risk for cancer is higher than it actually is. So that's a lot of what I do, is talking to women and having them get a clearer picture of their risk for breast cancer and their risk to have a hereditary factor for cancer. And then if a woman does pursue testing, if it's indicated for her, she pursues it, and then we find out that there is a mutation in the family. Of course, the next question is, what can I do about this? How does this affect my family? So if someone carries a genetic factor that caused their cancer, their children and their brothers and sisters, men can carry the mutation also, have a 50% chance of also being carriers. And as far as what people can do to reduce their chances of getting a second cancer or from getting cancer at all, include screening for cancer more frequently and also earlier than what's recommended in the general population, because women are at risk for early onset breast cancer, so we wouldn't start screening at age 40. It's recommended by a panel of experts who study hereditary breast cancer to start screening for breast cancer at age 25, so much earlier than the general population if there's a hereditary factor. And then we want to screen more frequently. If you have a high chance for cancer, you want to catch it as soon as possible at the earliest stages when it's most treatable. And so what's recommended is also including MRIs. And Dr. Chen, very elegantly illustrated to us that it's good to do both modalities in some situations, especially for high-risk women, because what mammograms can't pick up, perhaps an MRI can. And so it is recommended to include MRI screening annually, add that to the regimen for women at high risk for breast cancer due to genetic factors. There's also tamoxifen. It's a medication that's given to women who have breast cancer to reduce their chances of getting it again. But it can also be given to women who've never had breast cancer to reduce their risk of ever getting breast cancer. It can reduce their risk in half. And that's a very important issue for women who have a BRCA1 and 2 mutation, because their risk for cancer can be as high as 87%. So if there are options to reduce that risk, that's something that women want to know about. And tamoxifen can reduce that risk in half. And it's a pill that's taken once a day for 5 years. And then also there's surgery. Surgery has been proven to be beneficial in greatly reducing the risk of ever developing breast cancer for women who have a BRCA1 and 2 mutation. It reduces the risk significantly by about 90%. And bilateral mastectomy is the surgery option for women who are at risk. But of course, surgery has its own risks, so it's something that should be carefully considered and weighed as far as the risk and the benefits for each woman. So those are the main options for women who have a hereditary factor playing a role in cancer. But again, counseling can be pursued by anybody who's concerned about their risk for developing cancer, or for anyone who's developed breast cancer and are concerned, what are my chances of getting it again? What are the chances of my family, my female relatives to develop breast cancer now that I'm at risk? And that's what I do, is talk to women who are concerned about these issues to give them a more clear picture of their risk factors, their hereditary risk factors. Thank you.
My name is Maia Caramel. I feel a little bit unsure having come after all these amazing experts who have all this data, but I'm going to speak from an expert position of being a survivor of breast cancer. And that's where I come in. I run the foundation, Tiger Lily Foundation, but I was somebody who I didn't think would ever get breast cancer. My mother was a nurse, and she taught me to do my breast examinations at 13 years old. And I thought she was absolutely nuts and told her so. Got in trouble. But I began my exams at 13 years old, and my mother told me, she said, Maima, you may never get breast cancer, but the important thing is to know your body very well, because as your body changes, as you grow, you're going to have, you might get lumps in your breast, and you should be aware of your breast health. So I want you to know how your body feels. And she took me in front of the mirror and showed me how to do my exams laying down, standing up, and she made sure I did them monthly. And so it became a habit. I didn't have to have a wall sticker or, something in the shower. It was part of my lifestyle. And lo and behold, 18 years later, when I was 18, now 31, taking a shower, I realized I had a lump in my breast. And I knew that it was something that didn't belong there because I've been doing my exams for 18 years. So I went to the doctor, and my first recommendation, and she told me that I could not have breast cancer. I was too young to have breast cancer, to go home and forget about it. And I had to push for a biopsy. She said, well, we'll do an aspiration, which is unsuccessful. But she said, I really doubt you have breast cancer. You're too young. The women we're getting here are 40 and over, and you have a young child, you're a career woman, you're aggressive. Just, come back in a year or so and we'll look at it. But my mother's teaching had stuck in my head, and so I pushed for a biopsy, and 6 months later I found out I had breast cancer. And not only was it breast cancer, but it was aggressive breast cancer. So within a couple of months, as all of you know, you find the right, with weeks and weeks, find the right doctor, surgeon, oncologist, radiologist, and I was unprepared for what I had to deal with. Imagine you're a young woman who's 31 years old or 21 years old, or there are girls who are now 18 we're seeing teenagers. You're dating, you're having a good time, you're just eating noodles for lunch, you're in college, barely paying your rent, or just gotten married, and you have to deal with this cancer diagnosis. How do you cope with it financially, emotionally, mentally, lifestyle issues? Who do you turn to? And so the first thing I realized was that people under 40 were unprepared to deal with cancer because they weren't prepared to deal with that thought at that age. You think it's your mother's diagnosis or your grandmother, not yours. And then I began to look around for support. Everywhere I called would say, well, we support breast cancer awareness. We can support you in treatment. We can have somebody talk to you. But there weren't people that were my age. There weren't people that were offering support and resources, and I was terrified. And incidentally, thankful to the doctors who work in Inova and in other hospitals as well, I found the right surgeon, the right radiologist, and the right oncologist. And I had my surgery. I had a lumpectomy, and I made the right choice with that, I think. I had months of chemotherapy. So within 1 month, I had my surgery. A couple more weeks, I was bald, and then I had radiation for the rest of the, 6 more weeks. So a whole year of treatment with a young child, being a single parent. And I lay in bed and I thought, how many other women are there living with this disease under 40 who do not have support, who don't have services? While it's so vital to have money going into research, there's a whole other gap of what do you do between the diagnosis and the race? What do you do between that time of getting support? I learned there were about 11,000 women at the time in 2006 getting breast cancer under 40. There were 10% dying because they were misdiagnosed. That's about 3 women a day under 40. And these girls are between the ages of 18 and 40 years old. So I lay there and I thought, I can sit here and complain about my problem, or I can fix the problem. So Tiger Lily was born while I was in treatment to help women under 40 become aware of their breast health, to know the facts. The facts are important. Women don't generally get breast cancer at a young age, but if you get it, it's more aggressive. There's not a lot of support, and they have a higher rate of mortality because they are unaware. Doctors who are excellent physicians do not know that women get breast cancer. So doctors are great at what they do, but if they don't know and you go to them and say, I have a lump, oftentimes they might say, well, come back in 6 months. But it's faster growing when you're young, so you don't have 6 months to wait. Like I waited 6 months. It had grown from stage 0 to 2. If I waited 6 more months, I would probably be dead today. So what we do with Tiger Lily, I literally began it in bed, is we really go into the community. We teach, we go to high schools, middle schools, faith-based organizations, businesses, everywhere, supermarkets. As my staff, we approach people everywhere because every woman under 40 potentially could get this disease. She may not, she most likely won't get it, but if she gets it, she has to know that she's not alone, and we're there to support her. And so what we do is encourage these girls to come to us for support, to know they're not alone. When women get diagnosed under 40, they're terrified. The doctors can treat them, like I said, physically, but then there's, the depression, there's the fertility issues, there's the boyfriend can't handle it. And one of the girls we supported said her boyfriend made her wait for a year to have her treatment because he didn't want to deal with her having one boob and no hair. And so these are issues that women under 40 do face. There are girls who are contacting us who have to make a choice between she just bought her first house and she's a single mom, or a young mother and the husband and her are struggling. She can't work full time. They're going to lose their house. They can't pay the mortgage. The light bill's getting turned off. The light's getting turned off. So they come to us for support. So what we do is when the girls contact us, first of all, Tiger Lily provides peer-to-peer matching. We send the girls an email, or we link them on Facebook, or we get them, texting together. And right away, this woman who's totally alone at first and scared has about 10 new friends or more than she could actually need to support her in treatment. So her idea of cancer goes from this huge thing that's hard to deal with to, okay, these girls did it, they're survivors, they've been through it, or they're going through it with me. They're in chemo as well, they're in radiation, and they're scared. Even the girls who are metastatic, we match them up and they realize they're not alone. And that's a huge factor in your treatment, in your healing and recovery. And so then we send them buddy bags as well. There's, when you're in treatment, oftentimes it's cold in the infusion room, and you get these little plastic things to squeeze when you're doing your blood draws, and everybody's touched them and they're kind of icky. We have little balls for them to squeeze that are just for them with their own, and then we have blankets we send them. We send them pink boas. We send little presents, aromatherapy packets in the bags as well. We also pay for young women's bills. So they're literally unprepared to deal with the financial repercussions as I was. I had, honestly, when my treatment ended, I had 2 shopping bags from Nordstrom with bills. Because after a while, I just couldn't keep up, and I was dealing with the child and my treatment. So the girls write to us, and my chief of staff is here today. She will attest. We get a lot of calls a day, 4 to 5 calls a day from women all over the country that are, in treatment, and they're getting their cars taken away. They can't pay their treatment bills, and we help these girls with hands-on support and services. We also send the girls meals. As you all know, nutrition is very important. And it's more so important when you're in treatment for breast cancer. You have to eat healthy to give your body the strength it needs to be fortified as you deal with the chemotherapy and radiation therapy as well. So we send meals to young women, and closest to my heart is recently one of my best friends passed away from breast cancer. So I began a program called Stage 4 to help support women who are dealing with Stage 4 breast cancer under 40. We educate them about what the other options are. There are girls who are coming to us who are pregnant with breast cancer. So not only is it aggressive, and if they're estrogen receptor positive, the cancer is being fueled by estrogen, and they're pregnant. What do you do? And so we have partners in place with a group called Pregnant with Cancer and other groups that help these girls deal with it. We help to link them with, if they need hospice at some point, to partner with a hospice organization. We help their families to learn how to cope with this disease and how to help them along. And so what Tiger Lily does is really go out there, educate the girls wherever they are, even in homes, support them during treatment and after breast cancer as well. A lot of our education is pretty much hands-on. My daughter, Noelle, is here with me today, and she's also very involved because this is about her. This cancer thing, it starts, women get it mostly over 40, but if you get a young girl aware of her body, making healthier choices, Pop-Tart or banana, we discuss it every day, she and I. You make better choices. And when we had a fight in the car, but she had her Pop-Tart. I said, "Are you going to come here with me, and I'll have you have your Pop-Tart?" So she won today. But it's what it comes down to is like, how do you teach the girls early enough so they make the right choices about their nutrition, their lifestyle, their stress management, so their bodies are stronger, so they're equipped to handle, because bodies that have cancer, they're formed, maybe it's external risk, it could be environmental, it could be genetic, it could be stress management as well. So we give them the tools they need to become more empowered so they can make wise choices when they're older. And if they're 30 or so and find a lump, they can go to the doctor and get treated, and their bodies are strong enough to handle the treatment and hopefully get diagnosed early and survive. You spoke about the breast cancer recommendations of, the mammogram recommendations that came out last year about the, telling women that they don't need to start getting breast cancer mammograms till they're 40 and over, and that breast self-examinations weren't that important. And when I saw those recommendations, I screamed. I was so, I'm not going to even be PC about it. I was angry because a lot of the girls that coming into us, if they're under 40, they can't get mammograms because their breasts are too dense. And when they get them, like when I got them, didn't show my breast cancer. It told me the mammogram said, it read in a way where it showed that I didn't have the disease. So all I had was my breast self-examination, which is how I found the lump. And we have no other tools for women who are under 40 because it's just not, the imaging is just not where it could be yet. And so BSE is all we have at the moment, and eating and lifestyle and prevention and nutrition and diet. And so I tell the girls, you must do your breast examinations every month. You must watch your diet and your lifestyle. See your doctor and get a clinical exam every year. And if you find a lump and it's not going away and it's getting bigger, get a mammogram. I don't care how you get it. We'll find you a doctor. You're going to get it. And we pay for if the hospital or the insurance won't cover the cost, we'll pay the other part of the cost for the girls to get the mammograms. And so pretty much that's what Tiger Lily does. And I love what you're doing here at the hospital. All of you women are just really dynamic and really helping a lot of people. I wanted to share with you, last but not least, the most important thing is our Petals program, which we educate young girls through. I mentioned that. Petals stands for Peer Education through Awareness and Leadership Support. So we get young girls in the schools to educate their peers one-on-one, because peer support and peer pressure, as you all know, when we were younger, is really important, what our friends say, even now. So we get the girls to teach their friends about their bodies and educate their peers and support them. They have moms who have breast cancer, they have aunts and sisters, and when they know earlier, we create women who are more compassionate, and young girls who are compassionate, who are loving, who have a heart for philanthropy and giving back in breast cancer awareness, and they're empowered. If they do get diagnosed early, they can get treated in time and survive this terrible disease. So if any of you want to get involved in our Petals program, you can see me after the event and get my card, and their literature is outside on the table. Or see Alessandra or see Noelle. She knows the program. She gives it all the time to her friends. She talks about breast cancer awareness at her school and cupcake fundraisers. And so thank you for having me, and this is great. Have a wonderful afternoon.
Last but not least, my name is Eric. I'm an oncology nurse, and I am the program manager of patient education, as Susan said, at Life with Cancer. And for most of my oncology career, I have been focused on issues of young adults with cancer. Our Life with Cancer is actually a member of the Livestrong Young Adult Alliance. Young adults are not supposed to get cancer. It's kind of an oxymoron, like male nurse. A little reference for you, all the Glee fans out there today. Young adults are supposed to be in college, moving away from home, getting a job, going to graduate school, getting married, having their first serious relationship, then getting married, having a child. But all of these things are forever changed when they hear that word, that diagnosis of cancer. A young adult walks into an infusion clinic and is immediately surrounded by cancer patients, all of whom are 20 years older than they are at best. They feel isolated, panicked, scared to death. And I have heard over the years young adults sometimes being categorized as non-compliant. That means skipping their meds or maybe skipping an appointment. And I think it's really important for us to think about that as healthcare providers, and I talk about this a lot. These are young adults. Their coping skills have not really been fully formed. And all of those developmental milestones I mentioned are now completely changed. There's a major loss of those things, a loss of a sense of control over their lives. And at some point, they feel like they just need to take something back, take a little bit of control back. And that's why I think young adult programs, support groups are so important. Yeah, it's very, very serious if they make that choice to act out and skip an appointment or skip medicine. So coming to a program, whether it be online or live face-to-face, gives them a place where they can feel a sense of normalcy again. Maybe not their healthy peers' normal, maybe not my normal, but it's their own normal, and they begin to feel quite validated. In the group, we talk a lot about loss of all of those things that I mentioned earlier. We talk about things like dating. When do you tell someone you had cancer? Is it before you go out on the date with them? Is it after the third date? Is it after the seventh date? These are big questions for the young adult population. We talk about sex, how their bodies have changed, how that has impacted their libido and sexual functioning. We talk about insurance. We talk about employment issues. And we talk about loss of their healthy peers, their friends, their college buddies that can't cope anymore or can't cope with having a sick friend. And a lot of people think that support groups are depressing. But I gotta tell you, I have never laughed so hard as I do at some of those in some of those support groups with those young adults. They are incredibly funny, witty, and they have an incredible perspective on life. For example, if anybody has seen the Planet Cancer, one of their logos, one of their slogans for Planet Cancer, which is an online support program, is "We've done drugs Keith Richards never heard of." But my all-time favorite, and the one that I will leave you with, the one that our support group came up with, yes, I'm bald there too. So we have a support group for young adults. We have a separate support group for young adults with breast cancer. And we have information outside there on our table, and I would just leave you with that. So thank you very much.
Okay, great. Thanks to all of our presenters today. We do have some opportunity for some questions. If anybody has any questions, I'm going to bring the microphone over to you. We are recording this, and so it is not so that we can hear you in the room, but so that the recording can be on the presentation. So,
Thank you. You
sure.
just have to be like this far
Okay.
away. So you don't
Okay.
have to be right in their face or
Okay.
anything.
Does anybody have any? Okay.
Thanks.
It has to be a hold up far away. That's okay.
Okay.
All right.
Thank you all. It was very, very interesting. And I have a question for the geneticist. I'm sorry I didn't catch your name, but, pardon?
Grace Ann.
Grace Ann. I'm a little unclear about if my father's family had the genetic predisposition, could my father pass it on to me? And could I, if I have a genetic predisposition to breast cancer, could I pass it on through my sons, either for them, to their children?
Yeah, so you can inherit a genetic susceptibility from your father's side of the family. So that's an important question because sometimes women don't think about their father's side of the family when they're reporting their family history to me. So I'm very aware of that, and I make sure to ask people about both sides of the family. So you can inherit a genetic factor, a breast cancer gene from your father, And it's also something that you could pass on to your sons, and then they could then pass it on to their children. So I do see male patients who have a mutation in their family, and they have children, and they want to be tested to see if they've passed the mutation on to their children. So that's an important question, because father side counts too.
Thank you.
How soon can my daughter be tested for the genetic gene if I'm BRCA2 positive?
The recommendation is to wait until they're 18, when they can give consent and they can make a decision about whether or not this is something they want to find out, because not everyone wants to know that information. And there's no medical reason to find out before the age of 18, because like I mentioned during my talk, screening doesn't start until the age of 25. Or it can be 10 years earlier than the youngest diagnosis in the family. So let's say someone in the family was diagnosed at 28, then, perhaps the person does want to find out at 18 exactly, because that's when they may want to start screening. So we want to wait until they're adults for testing.
Okay, I have one more question. It's for Dr. Lear. What are you doing for education to the doctors in the area to let them know that when somebody comes to them with issues with the breast, that they can just consult with you immediately?
Yeah, and actually, when I first got here, and I've been in practice now here out in Loudoun for a little over a year now, I went to all of the departmental meetings and really spreading the word out there that really it's not just you need an abnormal mammogram, you need a lump in the breast, that definitely I'm here to do risk assessment and to design that very personalized breast cancer screening protocol based upon each individual's risk factors, and also certainly am capturing that population who I need to send on to Grace and to refer to her for a talk about testing. And also I sent out letters to pretty much all of the primary care docs, the OBGYNs, the internal medicine docs, pediatricians, when I got here, saying that this is what I offer, please send patients my way.
And if I can touch on that too, one of the most important things that we've done here at all of our Inova hospitals is to go for a certification to become a National Breast Center. And part of that certification process does include education to the medical community. So while we have an event like this here today for our patients, we also have numerous events with Dr. Chen and Dr. Lair who participate to educate those providers that are out there. We send out newsletters, we do some education, because as many people have said, that there is kind of a knowledge gap sometimes in some physician practice, and that's one thing that Dr. Lair and Dr. Chen have been wonderful to do with. We also host monthly and bi-monthly breast cancer conferences at the hospital where physicians get to come, and it's a multidisciplinary approach to looking at the patients that have been diagnosed with breast cancer, and educating all the physicians there on new treatment options and really new ways to diagnose patients, because we do always have some surprises for some patients. So it's a great question. But it is part of our mission here as Inova to really educate the medical community as well. So, question?
Yeah, this is for Grace Ann. My maternal aunt was diagnosed with stage 4 breast cancer 8 years ago, and I was diagnosed last year, and I was only 35. And so just 2 months ago, her daughter is 40 and was diagnosed with breast cancer, but we've all been tested negative for the genetics. So is there some concern that we should be thinking? Because now my family is like terrified who's going to be next and how, are we going to get it again?
Yeah, because BRCA 1 and 2 doesn't provide the answers to all families. So your family still does sound like a family that meets the criteria for hereditary breast cancer. We know that there are likely other genes that haven't been discovered yet, so we can't test for them. So you testing negative doesn't rule out hereditary factors. It's very important to still look at your family history. And for the other women in your family to know their family history, to be armed with that, because for them, MRI screening would still be recommended. Women who have at least a 20% risk, and sounds like the women in your family likely would have that risk of developing breast cancer in their lifetime, are eligible for MRIs and increased screening. So the women in your family who are concerned about their risk because of their family history can still be treated like a family that we actually find a BRCA 1 and 2 mutation. So
Should we be concerned about it though? Like,
definitely, yeah, I would say so.
Thank you.
I got breast cancer at the age of 34. So I had breast cancer. My neighbor to my right had brain cancer. My neighbor to my left had ovarian cancer. The neighbor behind me had breast cancer, and the woman across the street had breast cancer. And the woman down the block had breast cancer. So I'm from Long Island, which is it's like an epidemic up there. However, I apologize, I just got here, so I didn't get to hear the whole panel. But my father's sister got breast cancer, and then her daughter got breast cancer, and another cousin on that side. So can it be a combination of environmental as well as?
Yeah, we don't know all the reasons why breast cancer occurs. Environmental is something probably one or the other people on the panel could talk about. But definitely, based on what you're telling me about your family history, if there are early onset breast cancers in the family, and the fact that there's multiple relatives. So when we see at least 3 relatives in the family, regardless of their age, and they're close relatives, so, parents, aunts, they're considered close relatives, nieces and nephews, then that's enough of a reason to pursue testing, because not every family looks like the classic family with early onset breast cancer. So there's various reasons why we would recommend genetic testing, and one of those is if there's at least 3 close relatives in the family. And as far as the environmental concerns, patients ask me about that all the time. I don't know if you have any feedback about that.
Unfortunately,
especially Long Island, it comes
it's
up
very
a lot.
hard to tease out environmental issues, and so it may be, but at this point we don't have any clear environmental causes for breast cancer that we can identify. But again, that research is very difficult to do.
I know the EPA was doing a study up there.
Very difficult, though.
I was in Sloan Kettering, and the breast cancer ward was completely full, and it was overflowing to the other rooms.
I'd like to know if breast cancer in men is static at 1%, and also the issue of gynecomastia, is that at any age?
Well, gynecomastia is basically what that is the development of breast tissue in a man. Developing breast tissue, and actually all men do have a small proportion of breast tissue. Most of it's kind of rudimentary, but having gynecomastia does not increase a man's risk of development of breast cancer, believe it or not. And that's kind of looking at the same way, whereas a woman with larger breasts don't necessarily have a higher risk of development of breast cancer. There's just something about the cells that you have that may, that they just decide to mutate one day. And gynecomastia can occur at any age. We typically see it in the younger patient population, so adolescents, 20-year-olds, and then sometimes in the older patient population. But there are a number of different factors, drugs, environment, illicit drugs that can, certain medical conditions that can cause gynecomastia. But certainly you always want to make sure that you're just dealing with gynecomastia and not a breast cancer, because, I should point out, and as we've already said, men are not immune to breast cancer. And as far as the statistic, as far as 1%, I'm not 100% sure, and I'm just being honest, I'm not 100% sure what the incidence of male breast cancer is. It is obviously much, much, much less than in women, but it's not 0.
In 2009, it was 1% of all newly diagnosed breast cancer cases. It's actually a little shy of 1%. It was 0.8 of 1% were men. Were found in men.
Hi. I was diagnosed almost 6 years ago with breast cancer, and it has metastasized a couple of times. I'm doing very well with it. Now, my mother also had a brain tumor, and my aunt had breast cancer and ovarian cancer. Now, what is the risk factor for my daughters? I mean, I know you were saying that the hereditary risk is not that high, or based on my situation, family history.
High in general of all breast cancer cases, but it's about 5 to 10% of all breast cancer cases. But we really analyze your family history to see if you fit into that portion, that 5 to 10%. And part of that is ages of onset? Is there ovarian cancer in the family? And that raises the chances that it's hereditary if you have some of those features. So from what you're telling me, it does sound like your family has some features of hereditary cancer. So, you know, if you wanted to talk with me or get some type of genetic counseling, that might be useful for understanding your risk and your daughter's risk for hereditary cancer. And even if we don't find a mutation, there still can be a discussion about, there's risk models that exist where we can plug in people's family history of information, and then a number comes out to let you know what's your lifetime risk of breast cancer. So that's something that can be done for your daughter, even if we don't do genetic testing. There's still a counseling process, a risk assessment process that could be helpful for her to understand her risk, and then know what options are available to her as far as MRI, for example.
Thank you.
Have any other questions? Sure.
If you've had breast cancer in the past, and then since now it's wonderful to know you, I come and visit you and find out there is a positive gene, is there a likelihood that my breast cancer would return?
So as far as the genetic factor and having a gene mutation, we talk about the risk of getting a second brand new cancer, not a recurrence of your current cancer. Recurrence has more so to do with the aggressiveness of your disease, you know, how it was treated, and I'm sure one of you could talk more about that.
No, you're doing a great job.
But no, you know, having a mutation doesn't say your cancer is more likely to recur. The original cancer is more likely to recur. It just tells you the chances of getting a second brand new cancer. Recurrence is something that your surgeon and your medical oncologist would be better to discuss with you.
Okay, do we have any other questions? Oh, good.
So the BRCA tests aren't, I mean, they're definitely not a guarantee about the second, type of cancer. If you have, I mean, I was negative on both, but I have a huge family history of all types of cancer. So just that my BRCA was negative, I mean, I kind of went, phew, I'm done, woo, yay. But from what I'm hearing now, maybe not so great. I mean,
Right. So it's important not to have false reassurance. I mean, it's good to rule out BRCA1 and 2, but they aren't the complete picture. So there could be something else running in the family. We don't know all the genes. We have 20,000 genes altogether. Several of them probably play a role in breast cancer. We've identified these two powerful factors that we can test for, but there could be something else running in your family. So, it's important that everyone in your family know about their family history, because you said there's other cancers. There's screening for other cancers also that your family may be needing to do earlier or more frequently. So definitely, ruling out BRCA1 and 2 doesn't rule out hereditary factors completely.
Okay, thank you very much. Again, I want to thank all of our presenters today and all of you for coming out to our event. Please stay, enjoy, talk to our wonderful vendors that we have here too, and enjoy everything. And if you have any other questions, please feel free to come up and ask somebody here. We're here to help. Thank you again. Thank you.